Well, I met Ignacio and other from this institute in a conference in Basel, and I saw the enthusiastic eyes during the talk and during the conversation later. So I know this technology will be implemented here quickly as we did in Tel Aviv, because all we need is just enthusiastic people and key people to promote it. So I'm an orthopedic oncologist. Orthopedic oncology, I know that part of this audience maybe is dealing with sarcoma tumors, but dealing with tumors, especially in the pediatric population, is very challenging. Sometimes the tumors are big and we are not choosing their location adjacent to joints, adjacent to vessels and nerves, adjacent to any structures in the pelvis. Huge pelvic tumors that we are struggling every day to resect with free margins. Free margins mean radical excision sometimes, and without with insufficient tools during surgery. Well, we have the hybrid surgical room, we have the Da Vinci robot, but then most of the time is the surgeon with the problem. Most of the time is a surgeon with his hand and the problem, and we are lacking instruments that would guide us. Where is the tumor ends? Where are the tumor margins? And would it be safe to put the osteotomy here or here? And we struggle every day to understand and to convert our vision from the 2D imaging, CT and MR, to the surgical field, to theater, to the real life. So this is a 9-year-old femur. 9-year-old femur with osteosarcoma. Osteosarcoma is a high-grade tumor. This kid will have chemotherapy, will have a session of almost a 1 year of treatment, but in between we have a window to operate to take out this tumor in free margins. So as you see, the involvement of the tumor is quite huge along the femur. This is the knee joint, this is the hip, and it's obvious, even in theater, even in the operating room, that this extension of the tumor here will be obvious to the eye of the surgeon, and even not a so experienced surgeon. But the involvement that we have here in the medullary canal, in the bone, is not seen. It's not seen during surgery. There's no imaging. Even if you have an intra-op CT, you will not see the involvement of the tumor along the femur when it is inside. So, two problems. When a surgeon encounters this kind of problem, he will tend to go radically and excise and resect all the hip joint. And the other problem, distally, when it is so close, so adjacent to the joint line, a surgeon will not take the risk to go intralesional through the tumor. So he will excise the knee joint. So the result is excising and resecting all the femur with hip and knee in a 9-year-old kid, and reconstruct it with a metal piece, because there's no other option. When you remove all the bone, there's no other option. You just take off everything and you resect all the ligaments and the capsules. Then you end up in a constrained hip and knee joints with a metal piece. We'll leave aside the lengthening of this procedure and the lengthening of a kid that's still growing. It's a problem. We'll not deal with it at the moment. There are some solutions. But a metal piece, a metal prosthesis, megaprosthesis, a 9-year-old kid, this kid is doomed to go back and forth to hospital, back and forth to the operating room like a car, like a replacing parts, replacing the joint, and the mechanical problems, infection problems, very high rate of infection rate, and sometimes they will eventually end up with an amputation because of the morbidity. So here comes 3D technology. And as you can see from this CT scan, we put on top of that the contour of the tumor. You can see the extension in the distal part of the femur. Then, as you see in the model, this is the digital STL file after fusion the tumor from the MR and the CT and the bone from the CT. We are fusing them together, the 3D objects, because we don't have yet tools to register the CT and the MR before doing this 3D objects. And after visualization, the advantage of visualization, the involvement of the tumor inside the bone is making the change. It's the game changer, because when I know this kind of the end of margins, I can plan osteotomy very close. So I know that from the literature, I can go up to between 5 to 10 millimeters to the margins of the tumor. So I will challenge my surgery and will leave this kind of slice of condyles. Even though it's very thin, there's still ligaments attached, the cruciate ligaments attached, and the lateral and medial collateral ligaments are attached. So we will have a very good biological reconstruction with an allograft and a fibula, microvascular fibula allograft at the end. So instead of reconstructing it with a metal megaprosthesis with high rate of morbidity, we then end up with 2 native joints and reconstructing with an allograft and an autograft. Using this kind of tools, after deciding our osteotomy, the safe osteotomy oncology margins-free, we can then design our patient-specific tools. This tool is biocompatible, is done and 3D printed by a printer with a biocompatible material, and this tool is going with me to the surgical room to guide our osteotomy exactly as we plan, to execute our pre-surgical plan to the theater. And then we do the same with the allograft. We have the same set of jigs, same set of cutting patient-specific instruments, and cut the allograft. And this is, in theater, this is a 3D model, as you see. And this is from the surgery. As you see, the guide sits perfectly on the bone. This is the bone extension of the tumor. We fix it with K-wires. Then we have 2 slots, proximal and distal, to guide our osteotomy. This is on a side table, the osteotomy with the patient-specific instrument done specifically for the allograft. And this is the allograft, this is the tumor after excision, and the jig, this is the post-op X-ray. So, in one very nice case to show, you can see all the flow and all the claim of everything that's dealing with 3D printing in healthcare and in the surgical field. Everything is understood and implemented in one small case, because preservation of bone, accuracy of the cuts, accuracy of the reconstruction, everything, all the flow of 3D printing and advantages of 3D printing can be claimed on one specific case. So I heard from you that you are about to open a service for all surgeons, as we did in Tel Aviv, because there are many surgeons that deal with 3D printing, but they are doing it with different companies. They send the DICOM data to a company. The company will then do for them the segmentation, they will print for them a model, or maybe a jig, or a cutting jig, a patient-specific instrument, but implemented this technology in a hospital needs a different scope, a different vision. And I'm a real believer of this vision, because a 3D hub in the hospital will make a difference, will make a difference in converting our thinking from 2D to 3D, because by sending a DICOM data, if an orthopedic surgeon sending a DICOM data, a CT scan or an MR to a company, and then just a day before surgery I will get this kind of model, I think it won't do anything. This surgeon that's do that will not adapt the technology, will not adapt the advantages of the technology. He will not be a fan of the technology, and he will not use it in the right cases, and he will not gain the advantages of being involved in the process. So 3D hub in the hospital, meaning surgeons are involved in the process. Surgeons are involved from day one while they're giving the engineer in-house their CT. It could be a disc, it could be imaging from the pucks. But then he sits with the engineer, he sits with the designer and doing and in being involved in the segmentation process and all other steps that I will tell you about. So this 3D hub bridged medical profession with 3D printing technologies. Well, we are clinicians, we don't know much about 3D printers, we don't know much about materials, we have to have those professionals with us. So the point of buying a machine, many centers bought a machine, thought, this is the solution. This is the solution. I have a machine, I will print everything I want, I'll print instruments, I'll print models, but then they got stuck. They are just not in use because they are lacking the knowledge about how to use it, when to use it, which material to use. So I think centers, medical centers should concentrate on the first steps of the process. Dealing with imaging, dealing with planning, we have the medical staff to do that. We have some engineers that can recruit and then bring them to sit and plan and operate and leave all the technical issues, materials, and printing to the companies. So it can be implemented in the center. It can be, but materials and machines are developing in a speed that we are not achieving. In the hospital, it's useless to bring a $1 million machine and then after a year, it's not relevant. So 3D hub in the hospital will be the liaison between the technology, the companies, and the imaging data. And even though printing can be outsourced, if we have the first steps in-house, we can produce all you see in the bottom of these slides. Instruments, models, model for simulation, patient-specific instruments, metal implant. We can just design and plan whatever we like. In this, we have a lot of freedom to do and leave the printers outside. So this is the model that we work in Tel Aviv. We use DICOM data from the imaging. We take it from the PACS. Hospital in-house printer sometimes can be useful for the day-to-day work, sometimes very small simulation before surgery. So you have to have a simple printer in-house and leave the complicated and fancy models and fancy materials and complex materials and printing outside. This is the model we have in Tel Aviv. This is the model that we have. We thought that we can share with us today. The company that works with us and the company sits with us in the hospital called Synergy 3D Med. It's an industrial designers company. So at the beginning, the first year, we started only with designers. So their knowledge of medicine was almost zero. So we sent them to anatomy and physiology courses, and they get some education about segmentation software. But their skills are very needed to plan the surgery. Their creativity, instead of engineers, we found that it's very useful to the surgeons to get some more angles and visions of planning. But at the end, must be an engineer inside. So all those stations here are steps of the flow. The segmentation step, the cut and planning step, and we have some tables and station to discuss with surgeons. This is a hub that surgeons come, and they don't have on a daily basis a hub that can discuss those surgeries enough. They are discussing it in the multidisciplinary meeting, in their inner department meeting, but there the politics and the agendas of everyone, and everyone has his own idea, want to impose the ideas on the others, and then at the end, when you put a CT scan and AMR, with, at least in our MTT multidisciplinary meeting, 10 surgeons, oncologists, everyone with different vision, then one surgeon goes and he does what he thinks. So his vision with his 3D image in his mind from the CT, his conversion of the 3D model just by looking at the CT and the MR from the meeting, is just his own. So we must standardize this vision that we can replicate the surgical outcome. So this is the model. It works very well. Surgeons come and they discuss without the cases. I refuse from day one to get images, and the surgeon goes and want to get the 3D model just before surgery. I impose him to sit. I just force them to be involved in the segmentation software, in the segmentation process, in the planning software. And this is the most important message that I want to give you today, that the technology is amazing, the outcome is amazing, but if you are not recruiting surgeons into the process, you're not gaining anything. The technology will run without the adoption of the surgeon of the technology and the advantages. So this is our hub. At the moment, we are giving services of pre-surgical planning, customized surgical models, patient-specific instruments, and customized implants. Up to date, till October 2018, 200 cases. Well, orthopedic oncology is a very big client, but we work with all other disciplines, and we are getting more and more experience. Everyone, surgeons come, and not always we know what will be his advantage of the technology. We explore the technology with them. We learn and study together with them what will be the best of visualization to show a cardiac surgeon or a chest surgeon or an invasive cardiologist. So everyone can take from the flow something, he will gain something. So sometimes I can give him patient-specific instruments to guide a saw, a blade saw, but then others, we will not operating on heart with a saw. We cannot do this to replicate this patient-specific instrument to a chest surgeon, to a liver surgeon. So we are focusing on the visualization to get them better visualization that we'll never had before 3D technology. And 3D printing is not only printing. Most of the technology is software and a segmentation software that eventually there are so much brands in the market, but at the end we have to visualize what's the best, and the best derived from the CT and MR. There's no new data in the 3D model. It's the data from the CT scan. So if the surgeon knows better all the details from the CT and MR, he should put them in the model. Nothing is new in the model. It's just a different way of visualization, a better way of visualization and understanding of surgery. So segmentation software, this specific workflow is from the Philips portal. Philips portal are working with us closely, developing this is the 10 version. So after doing the bone volume from the CT and separating parts, this is the ability of segmentation software to show us the tissue of interest. We can separate parts. We can then segment the tumor differently with on the MR, and then we can preview the model. The editing can be in this software and other segmentation software on the 2D images and the 3D images. So you have lots of options and features and segmentation tools that can help you to visualize the better what organ you want. You can put on if you want the vessels, the nerves, the inner organs, all the adjacent organ that rely on top of the tumor. So it depends what is the purpose of the surgery. It depends the approach of the surgery. And then at the end, you get an STL5, it's a 3D printable, file. This file can be given to the surgeon as a 3D PDF if he doesn't want to print. If there's no need for a model, at least he can take this USB with a 3D PDF to the surgical room, just plug it and see on a big screen the 3D model. And he can explore the 3D model while he is operating. And these 3D PDFs change our meetings and our way we work inside the surgical room. Usually, traditionally, we put the CT and MR and just go back and forth with sometimes new gloves just to roll another 2D image to understand where we are in the space of the surgical wound. And at the moment, we are working with a 3D model and a 3D PDF on the screen, and different way of looking at the surgery, different way of understanding the anatomy and the pathology during surgery. So models are so many models, so many materials. There are materials that can mimic human tissue, all human tissues. All the companies are working on mimicking human tissues from kidney, eye, vessels, just for look and feel of the surgeon, for simulation of surgery. Sometimes it's for a medical training, sometimes it's a specific organ to train before surgery. We had a project with the urology department. We printed 20 cases of kidneys with tumor, with carcinomas, and we gave some residents to work on the Da Vinci robot on top of the model. So they were training on a 3D model, but the consistency and the filling of the materials were exactly as a kidney, and they were operating on the Da Vinci on the model. So you can do whatever you like with models, but there are fancy models, there are very simple models, there are desktop 3D printers, and there are very industrial and complicated and multi-material, multicolor printers. Sometimes when we started, we just printed everything. We printed everything just because of our enthusiasm, but then after you work and get some experience with it, you understand that you don't have to print everything. You can limit the printing to the complex cases, and you can print with very cheap materials. There's no need always to do those very fancy multicolor, multi-material, at least to keep it to the complex when the surgeon needs to simulate and do some stuff by hand before surgery. So for clinical training, education, and surgery planning, well, we mentioned everything. The patient-specific instruments are those instruments that are, at least for the bone, sometimes it could be even for other tissues, but at least for the bone, they are derived from the topography of the bone. So we know after segmenting, and we have the 3D digital model, we know where are the margins that we want to have. So we plan those cutting guides exactly that will fit the bone surface. Sometimes it's difficult. In the distal parts of organs of bones, it's quite easy because we have the flare-up of the metaphysis with some landmarks to hold and to fit. But sometimes when you go further to the cylindrical, a long bone, it's difficult to place it. So we use some other landmarks, like outer earth marks. Sometimes we use the bony imprint of the head of fibula or malleoli, even with the skin. We segment the skin, and then we use them to put some references. In complex cases, we just bring the old friend of navigation system to register and place that, and then we use the navigation system to place the jig, but just in complex cases. We used to do that when we weren't confident with the technology at the beginning, 3 years ago, but at the moment we are using just this, plan it carefully before surgery, and just coming with this to the surgery. So this is a simple case of a Ewing sarcoma of the bone. Usually it was treated by intercalary resection, and in this case we left the anterior cortex intact as a bridge. This, the advantage of leaving just a bridge is leaving the component and the fragments intact to keep the continuity of the bone and the access of the leg during surgery. So this is the model with a jig, and this is the jig placed accurately with K-wires during surgery. continue with some examples. This is a 17-year-old girl with osteosarcoma of the acetabulum and the pubic area. So this is the model. As you can see here, the contour of the tumor in the CT. And this is the contour I bring it from the MR. This is after the fusion of the CT and the MR. We are not working only with CTs, with oncology. The tumor margins must be taken from the MR, and then we fuse them together. Usually, as you can see, those complex osteotomies around the joint cannot be executed without 3D technology. Without 3D technology, this kind of tumor, if this is the acetabulum, this is the pubic area, this is the anterior area, will be resected almost half of the pelvis, almost hemipelvic osteotomy and resection without the ability to reconstruct. So 17-year-old girl without the ability of reconstructing her pelvis, so the hip joint will migrate proximally, and she will be with a very dysfunctional hip joint, short leg, and old morbidity associated with it. So with 3D planning, after visualization, this margin of the tumor and understanding that it involving only the medial part of the acetabulum, so maybe to preserve the outer part, the lateral part of the acetabulum, it's mandatory, it's feasible. You will never think of that kind of osteotomy before the aid of 3D technology and visualization. So this kind of visualization makes you confident to do this kind of cut, and leave the outer part of the acetabulum as a weight-bearing area to reconstruct the hip. And then using simple jigs that will follow the topography of the bone to execute the plan. So this is the jig. It will allow me to do the osteotomy at the right trajectory. This is from the surgery. This is the allograft we use to reconstruct the medial part of the acetabulum. We use the same set of jigs to cut, as you see here in this picture, to cut the medial part of the acetabulum and reconstruct you can see in the post-op X-ray this reconstruction after reduction of the hip into its place, and fixing the allograft with the plate. And it's about 1.5 years from surgery. She is doing very well. Her legs are even, and her hip function is perfect. Another case of osteosarcoma of a 45-year-old male. This osteosarcoma is very big, invading to the the inner side of the pelvis. Usually, the exposure for this kind of sarcoma will be ilioinguinal incision, very big incision from the anterior, and trying to deal from the anterior approach, resecting this kind of tumor will end up exactly as the previous case with the hemipelvic resection, and the proximity of the tumor to the sacral ala, and this is the root of L4, L5, and the adjacent foramina S1, S2. So this kind of resection will include not only the iliac bone, just in the third outer part of the sacrum, sacrificing the S1, S2, and maybe to injure L4, L5. So not only the ring will be impaired, it's the nerve function. So we decided to go from the outer side of the pelvis, the intact part of the pelvis, without the tumor involvement, to develop and design this kind of jig with, I don't know how much, osteotomy line. So a simple exposure of the glutei from the back, and doing this kind of maneuver and just pushing the tumor from the back without dealing with the nerve, leaving the ring intact, leaving the sacrum intact, leaving the nerve intact. And this kind of maneuvers, this kind of freedom of designing a surgery and planning a surgery is given just by this technology. There's no other technology at the moment that bring you to this kind of creativity, even not navigation, even not navigation. With navigation, you can do a plan, but the execution is a problem because you have a freedom. It's not guiding you to the same trajectory you planned because you have the freedom to move your hands. Yeah, it guides you to the screen, but it's an online guidance, and you make mistakes by online guidance. So if you take these jigs that you plan from advance, you can execute a creative plan that are given to us just because of better visualization. And when you have the model in your hands, you can be creative and think even 2 weeks before surgery how you tackle the problem, something you will never had before that just with CT and MR. This is from the surgery. This is a model. We print sometimes the model in a material that can be sterilized, so the surgeon can hold it and understand better the anatomy while he is operating. This is the jig in place with some K-wires. This is all the glutei that were separated from the iliac bone. And this is another jig to just place the trajectory of the pins for reconstruction. Another use of our technology, we try to use in different application. Cryosurgery in orthopedic oncology is quite common. We are freezing tumor for many years, but we did it just randomly sometimes with an open source and sometimes with the closed probes. This is a giant cell tumor, aggressive benign tumor of the proximal tibia. You see the proximity to the joint line. This is very typical to giant cell tumor. Okay, so I will show it from here. This is the model, and this is after doing the cavity, we have the open cavity, and before 3D technology is used, the probes on top of a gel that we will freeze, the periphery and kill the remaining tumoral cells in the periphery of the cavity. Using it, these probes randomly in the space, in the volume, end up with a non-homogeneous cryoablation, and we never know if an area didn't get the proper temperature. So it gets to a -80, -60 Celsius, and with this technology, we planned a patient-specific instrument to guide the needles. We know all the properties of the needles from the company. We can place the ice ball in the volume of the rendering, and we just spread it homogeneously, and during surgery, we do some extra hole with trajectories of different thermometers, and then we turned this uncontrolled technique to a controlled technique that we know at every point the temperature that an area got eventually during surgery. This can help us if some cases will recur, the tumor will recur, we know, and follow up the same spot of the temperature that we record during surgery. So it gives us sometimes a control and understanding our local recurrences of those tumors, and they tend to recur. Another use is using this technology for planning implants. It's the same as we did before. We plan the osteotomies with a jig, as I explained before, but then we go a step further and plan for the same bone defect, we plan the implant. We have here an example. It's not the same as shown in the presentation, but it's all the same concept. This is a tibia with after it's about 12 centimeters of resection because of high-grade tumor. Before the 3D technology, we would reconstruct it with an allograft, a simple allograft or microvascular fibula, or a very complex metal piece with stems, so it goes proximal and distal. But this technology is very elegant and allow us to print and to design different kind of implants we couldn't before, because this kind of lattice structure is very complex. It can be produced only in 3D printers. Just printing can bring this lattice complex structure. This structure allows osseointegration. Osseointegration means bones that grows from the adjacent osteotomy to the metal part. If we do a solid part, it will never fuse, it will never promote osseointegration. This kind of lattice structure, and we are still learning what is the best lattice structure that will promote the best osseointegration, but we see, from all our cases, we have about 30 cases of cages. We change a little bit along the years the structure, and we did those areas of the junctions more porous, less, very small porous to promote osseointegration. And then we get a perfect fit for the design of the bone defect, and then a biology is like a semi-hybrid technology, metal and biology reconstruction. We fill it with bone graft during surgery to promote osseointegration. So this is the jig, and this is the placement of the implant during surgery. I didn't put it here all the filling of the morcellized bone graft, but you have to believe me. And this is the post-op X-ray. Some other examples from other words: orthopedic oncology, this is still orthopedic oncology. We use a different kind of a visualization of implant to try to reconstruct and to understand what's the better way to cut this with a jiggly saw. I don't know if you are familiar with this simple technique, but then we use usually a freehand, and then we take some instruments to the lab, and with the surgeon we experience some instruments on the 3D printed models. We print the models with materials that they can work with and simulate surgery as much as they want. So, our advantages of the medical printing, the pre-surgical planning, well, I emphasized everything during the cases, but I will summarize it. Pre-surgical planning, modeling, and manufacturing eliminate the need for the intraoperative decision-making, accurate performance with patient-specific guides and tools, shorten surgery time, decrease the risk for patients as better clinical outcome and shorter recovery time, reduce surgery time and cost, and improve return of investment. Better clinical results, prevent amputation, decrease per expense, and improve quality of life. Models, implants, and instruments based on specific anatomy improve clinical outcome. Okay. I will run through other application in different disciplines, because it's not all orthopedic oncology, and this hospital will implement a 3D hub that is not only orthopedic oncology. So I will just say a thing that before we implement this 3D hub in Tel-Aviv Medical Center as an orthopedic oncologist, and it's unusual. In other places in the world that they have 3D hubs are promoted by radiologists. I don't know how much your radiologists are keen to be involved in this kind of project, but it's mandatory. We did succeeded without the radiologist, but it's not a good example. It's not a good example. We try to recruit them and involve them in the specific cases, and sometimes they come with their expert while planning or segmenting, but they are not involved in the whole project. I think the good thing to do is to bring them to be involved from the first step, the initial step of building and developing this center, this hub, because the first step of segmentation needs some imaging understanding. As orthopedic oncologists, we use a lot the imaging, so we understand better than other disciplines the imaging. There are some centers that some disciplines that imaging is not the routine, the understanding of the CT of an NMR, so it will not be enough to the surgeon to sit, and he will have to have the assistance of a radiologist. So think about the key person to involve from the first step, building this hub. So from a pediatric orthopedic surgery, deformity of the distal radius, we planned 2 wedge osteotomies. with one jig that will take the surgeon to all the steps. It will take him to do the wedge osteotomies in 2 points in the distal radius, and then it close up and guide him to the fixation with the plate. So this is the open version of the jig, and this is the closed version of the jig, bringing the deformity to a good position and fixation. This is from surgery. This is the sew, and this is the guidance of the osteotomy. As you saw, the wedge osteotomies. This is the open version without the fragments of the bone. Now the surgeon closes the jig on itself. It fixed with K-wire, so it brings all together the fragments to the right position. And then in the closed position, it can drill the holes for the plate. So then the plate will be in the accurate place as we planned it before surgery. Clavicular fracture, it was a complex clavicular fracture that the shoulder surgeon, wanted to put in a autograft. So we planned the surgery to trim the edges in an accurate way with jigs, and then the same shape of jig aid us to cut the bone graft on the iliac crest. Normally, the iliac crest will just take a cube from the iliac crest. The surgeon will take a cube and shape it during surgery to the place of the fracture site, and it's always not accurate. It's always not accurate. We used to, along the years, to accept this kind of results, not accurate results, but at the moment, I think it's mandatory to use some accurate tools to improve our outcome. From a revision, the unit of joint replacement are working with us closely, mostly in the revision cases. The revision cases, they have difficulties to understand what is the amount of bone loss around the joint. So we help them to understand how they can place the implant, what kind of implant to use. We reduced all the sets that are coming to the theater, because now after this kind of planning, they know they are using just one metal piece. We have a library of those implants inside the computer, the software, so we can take from the library different kind of implants, and the surgeon will choose what is the implant it's better for him to use, and then he will go to the surgeon, will tell the nurse, just bring this and this specific number. So this shows the kind of simulation we do in our 3D hub. So this is a specific case of revision that a surgeon didn't know how much of bone he has, what kind of implants to use. So he just simulated all the surgery before. He placed the acetabular cup in our hub, and then replicated and executed in the surgery. This is an osteotomy of a fracture and deformed the calcaneus, two osteotomy with a jig to bring it to a place. The use of our models in neurosurgery are very common, especially to show the vasculature around the tumor, or the tumor that are located in very, very complex areas. In this model, we just put them some few holes in the skull. They simulated a surgical exposure from different opening in the skull to understand which exposure is better. Eye surgery, this is a case of a exophthalmos. They are doing an orbital release. This is a case of ENT and in-op case of carcinoma, recurrent carcinoma. They printed the model, understood that it's inoperable, and then they did just a cryoablation, inside the cryoablation, through the mandible, getting to the tumor with the same technique of needles we showed before. And then it's mandatory, well, this kind of model, even if I cannot deliver this kind of, to the surgeon, patient-specific instruments, I do the best in the model, doing a segmentation of the vessels, segmentation of all the trachea and the esophagus, and bring the anatomy to the maximum understanding from the surgeon, and use the model during surgery to understand the anatomy. Spine surgery, this is a Ewing of C3, a reconstruction with an implant. Same with L5. Cardiac surgery, urology, this is a bilateral multifocal carcinoma. Some of those tumors were cryoablated, some were resected. Liver surgery, scoliosis, they use us a lot to understand how to correct the angles. And that's it. Thank you.